All right, we're back again. I think the streaming service has been possessed, but we're here with Dr. Heidi Klessig, who is a trained anesthesiologist and pain medicine specialist. And we're going to talk about brain death and organ harvesting. If you are watching live, please share this with your friends so more can watch and join. And Dr. Klessig, tell us about the pivotal moment in your career where you started to question brain death and what it's all about.
Sure. I came to this very similar to most people. I came into it sort of as a surprise. I wasn't really thinking about brain death that day that I came in for night call as an anesthesiology resident. I reported for duty and was told I was going to go up to the ICU and bring down a brain dead man for an organ harvesting. And honestly, it kind of surprised me. I wasn't really thinking about what kind of differences there might be in anesthetizing someone with brain death versus anybody else. So I asked the doctor at the desk, I said, brain death, huh? Is there anything different about this case I should be aware of? And honestly, he made light of it. He laughed and he rolled his eyes and said, oh, just be sure someone's actually declared him brain dead. You know how eager the transplant team can be, which was not what I was looking to hear. So I took a deep breath and I went up to the ICU. I found my patient. He was a young man. He was about my own age at that time. He had been in a motorcycle accident and had sustained a severe traumatic head injury. The neurologist had been by and had gone through the brain death protocol and had checked all the boxes and thus had declared him to be brain dead. So I went to see my patient. Honestly, the first thought I had walking in there was how glad I was that his family wasn't in the room because, as if you've ever had surgery, anesthesia comes by and we look you over and reassure you that we're going to give you excellent care and you're going to be comfortable and everything's going to turn out fine. But, what would I have said if, I had his family there and we all knew the patient wasn't coming back? So I was glad it was just the two of us. When I looked at him, he sure didn't look dead. He was warm. He was pink. He was moving at times. He had good vital signs, blood pressure, heart rate, oxygen saturation on the monitor. He wasn't on much for drugs, drips, or infusion. So really, he looked just like every other ICU patient I'd cared for, and in fact, better than most. So I went back down to the operating room and I found the staff anesthesiologist who was going to be supervising me for the case. I presented these facts to him and he said, okay, Heidi, what is your anesthetic plan of care? And honestly, Mary, I was so brainwashed at the time. I actually said, I think I'll give the young man a paralyzing agent so he doesn't move during the surgery and annoy the surgeons. You as a surgeon know how annoying that can be, right? Why should a dead man move during surgery? Apparently, it didn't really dawn on me. And then I said, I'm going to give him fentanyl as a potent painkiller to prevent any swings in the blood pressure or heart rate that might damage the organs. And so my attending said, okay, that sounds reasonable. Are you going to give him a drug to block consciousness? And I was stunned. I said, why would I do that? Isn't he dead? And, my attending just gave me this long, cool look over his operating room mask. And he said, why don't you give a consciousness blocking drug just in case? And he walked away. That made no sense to me whatsoever. Why should a dead person need a consciousness blocking drug? But, to my regret, despite my doubts, I caved. I did what I was told. I assumed, here I am, I'm the trainee. Everyone else is going along with this. I mean, I've got a surgical team waiting. I've got the OR times all ready to go. Someone, an authority must understand this better than I do, but I just went along with it. And I'm here to tell you that young man responded to surgery just like anybody else. He had the same heart rate and blood pressure responses to the incision, to the bone saws, to the organ manipulation. He required the same types and amounts of anesthesia as anyone else. And frankly, it's my regret over this incident that motivated me then to do more research later in life, when I had the opportunity to look at the primary source documents and try to understand where this idea of brain death came from. And what I was stunned to find is that for the last 50 or 60 years, doctors, lawyers, philosophers, scholars have been fiercely debating in the academic literature whether brain death is in fact death. But meanwhile, the public has never been informed of this. The public is given absolutely no type of informed consent process when they're asked to be an organ donor. They show up at the Department of Motor Vehicles, and here's a person with no medical or legal training whatsoever asking them, do you want to be an organ donor? And people, I find people, when I talk to them, mostly assume that, when I'm an organ donor, I'll be dead in the same sense maybe a pet dog or a pet cat, a dead squirrel on the highway is dead. But that's not the case at all. Organs are very delicate structures. Organs, things like heart, lung, liver, kidneys, are very dependent on a continuous supply of oxygen through the bloodstream, and very quickly become unsuitable for transplantation once that stops. So organs really can only come from someone who is still biologically alive.
Right. And, we all know absence of pulse is death, right? If you can't find a pulse and the person stops breathing. But what are the subtleties? What is the definition of brain death as it's used now?
Yeah, that's an excellent point. For thousands of years, nobody needed a doctor to tell them if someone was dead or not. People could recognize death on their own. And as you bring up, death was recognized at home, on the farm, on the battlefield, by the loss of heartbeat, the loss of breathing, and critically, the passage of time to be sure there was no possibility of resuscitation. When I speak, I find there are very few pure materialists out there. Most people believe that death at its source is that separation of our body, our physical nature, from our spirit, our soul, or our life principle, our immaterial nature, right? But, we don't have any type of device to be able to detect when an immaterial essence departs. So we are reliant on these physical signs of biological death. And historically, those have always been the loss of heart rate, the loss of breathing, and the passage of time. That's where our traditions of the wake, the vigil, the visitation come from. These things were important traditions, not only to allow people to have time to grieve, but to be sure death had indeed occurred. But in 1968, 13 men at Harvard Medical School proposed a new definition of death. Now, why would they do that? It turns out in December of 1967, Dr. Christian Barnard in South Africa performed 2 heart transplant surgeries. And in America, this was something of great interest. So just a few weeks after the turn of the year to 1968, these 13 men met, and they decided that it would be a good idea to redefine people in a deep coma as being somehow dead already. And they wrote a landmark article in the Journal of the American Medical Association. It's called A Definition of Irreversible Coma. And, the skids were greased for this. They submitted their paper at the end of June. It was published in August. In this report, the committee interestingly never says that these comatose people are dead in fact. And in the paper, they refer to them as being desperately injured. And they say that these deeply comatose people's lives are a burden to themselves and to others. This paper, moreover, has 0 scientific references. They went on to say, our primary purpose is to define irreversible coma as a new criterion for death. But, does changing a definition change reality? Of course it does not. The only rationale the Harvard Ad Hoc Committee gave as to why we should redefine certain types of coma as death were utilitarian. They said that this new definition would free up ICU beds and it would remove the controversy over taking organs from comatose people to put into somebody else. And truly, this ended up being of great utility because this redefinition allows organ procurement to skirt what's known as the dead donor rule by simply, by the stroke of a pen, declaring certain comatose people to be dead already. Now, the dead donor rule is not a law, but it's a moral precept that is almost universally adhered to. It says that people must neither be alive when organs are removed, and neither may they be killed by the process of organ removal. But if I simply redefine you as being dead already, the dead donor rule is met by sleight of hand.
Mm-hmm. Well, yeah. So what are how do they distinguish between a temporary coma and an irreversible coma?
That's the tricky part. Doctors do not have a crystal ball, and that's where we get so many reports of people who were declared brain dead, then going on to recover and survive. There's only been one neuropathology study of brain death. It wasn't done until after, the Harvard Ad Hoc Committee proposed this new definition. It was done in around 1971 and 2. It is really the only prospective multi-center study of brain death. They took 226 brains of people who were declared brain dead using criteria that are stricter than what we use today. At autopsy, 10 of those brains looked normal, and less than half, only 40%, had diffuse changes of destruction. The principal authors of this paper concluded brain death is a prognosis of possible death, not a diagnosis. And this has continued to be sort of what drives brain death. I don't know when you went to school, but when I went to school, they gave us the idea that these people, because they had a brain injury, they were going to die soon anyway. And because of that, we might as well declare them to be dead already for the sake of organ procurement. In fact, this is where our law about brain death comes from. In 1981, a presidential commission was seated, and they decided that brain death could be death because back then they believed in 1981 that once the brain stopped working, biological death would very quickly occur. Now, again, if I say something's going to occur, that means it hasn't happened yet, meaning, again, brain death, their whole argument was based on it being a prognosis of death. But, counterintuitively, this turned out not to be the case. It would seem like if your brain was destroyed, you certainly would die, but it turns out that's not the case. In 1998, Dr. Alan Schumann, who's a pediatric neurologist, he did a literature search and he found 175 cases of people who had been declared brain dead enough to be offered the opportunity to become organ donors, but for one reason or another were kept alive. And these 175 people went on to continue living after this diagnosis. I mean, fascinatingly, one of them, a 3-year-old boy who had severe meningitis, was able to be cared for at home by his mother with a home ventilator and a feeding tube for 20 years before he eventually died of a heart attack with absolutely no brain. It was fascinating. I mean, I talked to Dr. Paul Byrne, who was involved in this young boy's care. He's known in the literature as TK by his initials. Paul Byrne talked, with this TK's mother, and she said, he's not difficult to care for. He gets a urinary tract infection once in a while. We give him antibiotics. He gets better. But after he did die of a heart attack, after 20 years of home care, she allowed an autopsy to be performed. And fascinatingly, he had no brain whatsoever. His meningitis had caused such severe damage that there was nothing left in his skull but a small, hard, walnut-shaped piece of scar tissue. They couldn't even cut it with a knife for pathology. They had to cut it with a saw. Yet wow. TK continued to live. And this is really the sticking point. Brain death is a prognosis of possible death, but it does not cause death itself. So this led to a reevaluation. Another presidential committee met in 2008, and they agreed. Dr. Schumann's work shows that, this brain death is not a prognosis of eventual death in all cases. So they changed the rationale for brain death from biology to sort of a questionable philosophy. They coined a new term. They called it total brain failure. And they said that at an arbitrary level of disability, a person is as good as dead. They didn't give any reason. They said, if you're not responsive and you can't breathe on your own, all right? I mean, really, any level of disability you pick is going to be arbitrary, but that's what they picked. They called it the neurorespiratory standard. And it's not even biologically true. Total brain failure is inaccurate because 20% of people with a clinical diagnosis of brain death still have brain waves on their EEG. And over half have a part of the brain still functioning called the hypothalamus. Now, people will say, oh, the hypothalamus, how important can that be? Well, it's pretty important. I mean, the hypothalamus is responsible for us maintaining our temperature. It's responsible for our salt and water balance, and so that's our blood pressure. It's responsible for sex drive, awareness, and pain. I mean, it's a pretty important part of the brain. And this has become a real sticking point because the way death is legally defined in the US for the neurologic type of death is that there must be the irreversible cessation of all functions of the entire brain for a brain death diagnosis, including the brain stem. But the fact that it is widely known and recognized that over half of these people have continuing hypothalamic function is at odds with the legal definition. And this has become a real problem because neurologists know that they could be sued because the way they diagnose brain death does not adhere to the law in the US.
So you have to have an EEG that's basically flat.
You would think so, wouldn't you? In the original criteria that in 1968 were proposed, the Harvard criteria, an EEG was required. Once it was learned that about 1 in 5 people still have brainwaves on EEG, the requirement was dropped. Right now, if you look at the newest, the 2023 American Academy of Neurology Brain Death Guideline, they come right out and say an EEG is not recommended because they know some people will have brainwaves.
So is it purely a clinical diagnosis or prognosis?
It is. And it's so interesting, because of this variance between the law and the way doctors diagnose brain death. The American Academy of Neurology solicited the Uniform Law Commission between about 2020 and 2023 to change the legal definition of death in the US. But after years of study, I was an observer to the Uniform Law Commission as they did this. The committee could not come to any consensus. I was watching their meeting as they met in Honolulu, and the lawyers were asking the study committee, now wait, what you're asking us to do is to change the law for doctors who aren't following it? I know. Why don't we have doctors just follow the law? I mean, this did not go over well at all. So in September of 2023, the Uniform Law Commission tabled their work on revising the Uniform Determination of Death Act. But just 3 weeks later, the American Academy of Neurology came out with their new brain death guideline. And if you look at their methods section, they come right out and say, I'll quote it, because of the lack of high quality evidence on the subject, a novel evidence-informed formal consensus process was used. Basically, because they have no high-quality evidence on brain death, they used 3 rounds of anonymous voting to decide on what the clinical criteria for brain death should be. Now, we've been declaring people brain dead for nearly 60 years. Wouldn't you think there'd be some high-quality evidence for it by now? This guideline states that brain death is a clinical or a bedside diagnosis, and that ancillary testing, things like brain blood flow studies, for instance, are only indicated in cases of doubt or inability to perform certain components of the exam. So the 4 pillars of the exam are as follows. The first one is unresponsiveness. Now, as doctors, we have no idea whether you're inwardly aware. We don't have a way to measure that. We can only test whether you are willing and able to respond, which is not the same thing. There have been cases of people who were inwardly aware but were unable to respond. I talked to one brain death survivor. Her name's Jenny He-Man, and she was declared brain dead after a doctor gave her a medication that interacted very adversely with her epilepsy medicine, throwing her into intractable seizures. And she remembers lying in an ICU bed on a ventilator, hearing the pat, pat, pat of the medical team's feet coming in. And she said, I heard my doctor say, this is a sad case, a young woman with 2 small children at home. And except for her dead brain, the rest of her is in excellent shape. But her husband is being so unreasonable and won't make her an organ donor. So many people could be helped by her organs if he wasn't being so unreasonable. And Jenny said, there was nothing I could do. I just had to listen to it. And she said, it was as if I'd lost the ability to find the connections about how did I used to move? How did I used to speak? How did I used to breathe? And she attributes her recovery to the efforts of an excellent nurse. She said, a lot of the nurses just treated me as like I was less than human. They'd ask me, hey, come help me move this thing, is what they'd say. But this good nurse said, Jenny, I know you're in there. I know that you can hear me. You need to try to take a breath. And Jenny said, I just searched for those connections. How do I take a breath? And then suddenly it clicked. And she was able to take a breath. She was able to get weaned off the ventilator. She made a full recovery. She, in fact, went back to school and became a nurse herself so as to be able to help people the way that nurse helped her. So again, unresponsiveness is not a good enough measure of whether someone is inwardly aware. The second pillar of the brain death exam, there can be no motor stimulus to a painful, no motor response to a painful stimulus. But the guideline, it's interesting, I'll quote it. It says, it can sometimes be challenging to determine whether a movement is centrally or spinally mediated based solely on clinical examination. They're saying, if you're a doctor, it's kind of hard, if you're moving patient, is it a volitional movement? Are they moving intentionally, or is it just a reflex, right? In fact, they allow certain movements, and some of them are kind of funny. I mean, they allow movements like moving a limb off the bed. They allow movements like reaching up toward the endotracheal tube, like kind of looks like the universal sign of choking. My favorite one is they allow, if your nipples are brushed, if you open your eyes, they're going to call that a reflex, right? Some of these are just, I don't know how
those
they
aren't
got
the
this.
reflexes I learned in medical school.
Not really, no. And so because they realize it can be difficult, to know whether your moving patient is dead or alive, they actually in the guidelines say, if you're not sure, you can ask a friend, ask a colleague is what they recommend. I mean, how scientific is that? It's very subjective. And then the third pillar would be the neurologic exam. And they give it about 4 or 5 brainstem reflexes that need to be checked. They check your pupil response. They check if shooting cold water in your ears makes your eyes go dizzy. They certainly are not checking the legal standard, which is all functions of the entire brain, including the brainstem. These are not being checked. And the last pillar is the apnea test, in which they withdraw the ventilator and observe for spontaneous breathing. And, they give parameters for blood gas results for it. But if you read the guideline, they say selection of targets for this challenge is arbitrary because they don't have data as to what blood gas levels would prompt breathing if the receptors were functional. So again, this is not science. This is very subjective. Interestingly, I have a quote from Dr. Elko Vidics. He's a neurocritical care specialist at Mayo Clinic. He was an author of the 1995, 2010, and 2023 American Academy of Neurology Brain Death Guidelines. He was at a conference in 2006, and he stated, the diagnosis of brain death is driven by whether there is a transplantation program or whether there are transplantation surgeons. I do not think brain death examination now in practice would have much, if any, meaning if it were not for the sake of transplantation.
Well, and transplants are the number one revenue source of hospitals that do them. Um, and I mean, what in your experience, and it sounds like with that first experience, there was a transplant team member waiting eagerly for you to declare this patient brain dead. I mean, is that sort of the situation that, and how does that work? How do they even know that there's a potential patient that they can, does a nurse call? Does the doctor have to make that call? Does the family make the call? How does that work?
Yeah, there is a reporting requirement from CMS in order for a hospital to receive Medicare and Medicaid funding. They are required to report anyone who might possibly become an organ donor. So, I mean, you don't have to be brain dead. I mean, you just have to be looking poorly, and they are required to make that report. Then a member of an organ procurement organization generally comes and approaches the family and tries to see if they can, make the sale on getting you to be an organ donor. Like, I saw your ex post about how much money this makes at your own hospital, and it's absolutely true. And historically, I haven't talked about the dollars and cents all that much because I think most people who are involved in organ procurement do it out of sort of a misguided sense of zeal, trying to help people who they think still have more of a chance than the person from whom they're taking the organs. But I was on a podcast, and the other guest was someone whose mother had been made an organ donor somewhat against her daughter's will. And when that daughter found out how much money the hospital system makes from organs that they gave away for free, she was outraged. And so now I do speak about it. The Milliman Actuarial Organization comes out about every 5 years with the billable charges for the transplant industry. And they did that last year in 2025. So if you would, let's just talk organs. We're not talking about tissues now. Let's just say we donated a heart, a couple of lungs, a kidney, liver, a pancreas, maybe some intestine. Just those few things are worth over $8 million in potential billable charges.
For one patient?
That's just the one patient, just those organs. We're not talking about tissues, things like skin, bone, heart valves, corneas. That's just those few organs. And if you look at the Milliman data, in the US in 2025, the transplantation industry was over a $60 billion with a B dollar a year industry, which is not something that's insignificant. I think dollars and cents do play a role.
Well, and as bad as it is or seems to be in the US, it's probably 100 times worse in China. Have you looked at what's going on over there?
Oh, yes. I'm so happy. Heidi Klessig from American Thought Leaders has a new book coming out on March 17th. And I would recommend that everybody take a look at that because it's really egregious what's going on in China. They're really a state-sponsored organ trafficking organization. For decades now, the Chinese Communist Party has been targeting the Falun Gong practitioners and incarcerating them, subjecting them to blood and tissue typing, and then transplant tourists from around the world, from America, from Western nations. In America, there are still insurance companies that will pay for your trip to go to China to get an organ from a prisoner of conscience. And when all the recipients show up, then they take that prisoner, and execute that person via the removal of organs that are then put into all the transplant tourists, which is really unconscionable. And because of the great lack of public outcry about this, the CCP has just been expanding this practice. It now affects the Uyghur Muslims, the Tibetans, the house church Christians. I've been seeing videos lately from Chinese parents saying that their children are being subjected to blood testing and health exams at school. And some of the Chinese children have begun going missing so that Chinese parents are keeping their kids home from school. It's absolutely horrendous what's going on. And if you think it's just over there on the other side of the world, I'm sorry to tell you, it's happening in our backyard. I was just on a program with Allie Hopper and Jared Sadulski of Guard Against Trafficking. They do work in Mexico interviewing cartel members who are incarcerated as part of their rehabilitation. And they're hearing, in addition to the trafficking the cartels are doing of sex and labor trafficking, they're hearing more and more about Mexican organ trafficking. They said one cartel member they interviewed told them that it's much easier for the cartels to fly an organ into the US than to smuggle cocaine. And one man said that the most recent victim that he had taken was a street child, a 12-year-old boy, and they'd taken that boy's right eye and shipped it to the US. And it's not at all clear that that young man survived that experience. And so they asked him, how can you consciously, what does your heart tell you about grabbing street children and killing them for organs? And the cartel member said, well, look, everyone in Mexico knows this goes on. And so if we see a child that doesn't have a parent right there with them, we figure the parents don't care. And if I don't grab him, someone else is just going to. So this is going on in our backyard. And they tell, naive Americans that, oh, come to Mexico and get your transplant. We have less regulation down here and it will go faster. And these Americans come down not realizing that, this is, a child is going to be pulled off the street to get you your organ.
Well, and people are desperate. So they're willing to overlook the facts. What about Canada and their euthanasia program? Are they euthanizing people and taking their organs?
Yes, they are. Canada is the number one euthanasia organ harvesting country in the world. And they're not just giving these organs to Canadians. One euthanasia victim just had his organs shot to the US, where I'm sure we pay better for them, right? It's a win-win for the Canadian government, monetarily speaking. And even in America, you don't have to be brain dead anymore to give an organ. There's some different ways that have been explored to increase the organ supply. The one that is actually really booming right now is called controlled donation after circulatory death. Do you have time for me to talk about that a little?
Oh, yeah.
Okay. So this actually started in the 1990s. People who are not brain dead, but who have a poor prognosis and are not expected to survive, or people who have simply decided their quality of life is unacceptable, can opt to allow their care and their support to be withdrawn in a way to allow organ donation. Their deaths are sort of planned events, planned to occur at a certain place in time to allow the removal of their organs. These people have to be given a do not resuscitate order, because all of these people could be resuscitated, but a decision has been made not to do so. So again, legally speaking, these people's deaths do not meet the letter of the law under the Uniform Determination of Death Act, which says for a circulatory respiratory definition of death that there must be the irreversible cessation of circulatory and respiratory functions. Again, these people could be resuscitated, so we really can't say that their heart and lung stoppage is irreversible. They've simply, with a do not resuscitate order, decided not to do so. The way this happens is they're taken to the operating room, their ventilator, their medical support is withdrawn, and the patient is monitored until their pulse stops. At this point, doctors observe, depending on where you live, a 2 to 5 minute observation period to be sure that the heart rate doesn't spontaneously resume. In my state, it's 2 minutes. In other states, it's 5 minutes, making your death or life sort of dependent on your geography more so than your biology. And this 2 to 5 minute idea, it's something that I think should make people stop and pay attention, because we all know that people are routinely resuscitated after just 2 to 5 minutes of pulselessness. And if you could still be resuscitated, you were never dead. There's a critical care doctor in Alberta in Canada who's done a literature search, and he's found people who have self-resuscitated with no type of medical intervention at all, up to 10 minutes after cardiac arrest. And some of these made a full recovery. And because of this, many European countries have banned controlled donation after circulatory death. Countries like Finland, Germany, Hungary, Lithuania, and Turkey don't allow this because they see it as being unethical. And last July, the New York Times, and I just revel in the fact I can agree with the New York Times once in my life on this. They have an excellent article that came out. It was called "A Push for More Organ Transplants is Putting Donors at Risk." And they gave cases of these controlled donation after circulatory death, or DCD donors. The one that horrified me the most was Misty Hawkins. She was a young woman with some cognitive disabilities. She was eating lunch when she began choking and suffered a low oxygen brain injury. She was taken to the hospital. She was not brain dead, but doctors told her parents that, Misty probably was going to not get better, and they offered her parents the opportunity to withdraw her care in a way that would allow Misty to become an organ donor. And Misty's mom didn't want her daughter to suffer, and she was told that maybe something good could come out of their tragedy, so she gave her consent. So Misty was taken to the operating room. Her support was withdrawn. It took 103 minutes for her pulse to stop. They observed a 5-minute no-touch period and then immediately began surgery because, as we mentioned at the top of the show, organs very quickly begin to degrade and become unsuitable for transplantation once that circulation stops. But sadly for Misty, when doctors, took that reciprocal saw and sawed open her breastbone and opened her chest, they found her heart had resumed beating and she was gasping for breath. Now, if you can gasp for breath, that also means your brain is working. So the surgeons waved off. The transplant team left the operating room. They found another doctor to stitch her back up. It's not clear, according to the report from the New York Times, whether she was given any anesthesia during that period. And an organ procurement coordinator called Misty's mom and said, "Gee, I'm sorry, it just didn't work out. It just didn't work out for Misty to be an organ donor," and never told her the facts. Did not tell the family what happened to their daughter. It wasn't until the New York Times approached the family for comment that Misty's parents learned the truth about what happened to her, which is, as a mom, I am absolutely horrified by that.
What hospital was that?
I believe it was in New York, but I don't recall which hospital it was.
So who is the typical patient that agrees to this? Is it a similar thing where they're sort of partially injured with a brain injury, but it's not severe? Is that the typical scenario?
Yes, it's generally a patient who has a severe brain injury, one that doctors don't think will get better, but it's not as severe as to meet the criteria of brain death. There was another case like this in my neighboring state of Illinois. A young woman with Down syndrome had a aneurysm burst in her brain. And again, she wasn't brain dead, but she was not expected to recover. Her parents, again, gave consent for a DCD organ procurement. Same thing happened. This woman, they were cutting down to her kidneys and found that the aorta had resumed pulses, and this woman also began to gasp for breath. Interestingly, in that case, when the county coroner got a hold of the report, the coroner called it a homicide, that this was straight up homicide. They had killed that woman by opening her up. It's just awful. And if you didn't think it could get darker, I'm sorry to tell you, it can. So there's another variation that people are not told about called NRP, or normothermic regional perfusion. With this, they want to use the DCD protocol, but they want to obtain the heart. And the heart is a very sensitive organ. It's very sensitive to low oxygen. So after the DCD protocol and the heart stops beating for the 2 to 5 minute standoff period, an NRP surgery begins with clamping off the blood flow to the patient's brain and then hooking them up to a bypass machine and doing a full resuscitation on the remaining organs. Now, why do they clamp off the brain? Well, if they did a full resuscitation with the brain getting blood flow, you might wake up. And so this technique is very controversial. It plays fast and loose with the definitions of death under the Uniform Determination of Death Act, because they change your definition of death in mid-procedure. So first, for the procedure. They declare you dead under the circulatory respiratory standard. They say you've had the irreversible cessation of circulatory and respiratory functions. But because they're going to restart your heart in your own chest, showing, how irreversible was that really, doctors then make you brain dead on purpose by clamping off the circulation to your brain. So now your death is declared under the second arm of the UDDA, the irreversible cessation of all functions of the entire brain, including the brainstem. So now when they hook you up to bypass and your heart starts beating again in your own chest, doctors are legally covered because now you're brain dead, right? This is really controversial. The American College of Physicians, which is the world's largest specialty medical organization, recommended way back in 2021 that NRP be paused. They said the burden of proof regarding the ethical and legal propriety of this practice has not been met. But that's fallen on deaf ears. I mean, the practice is actually increasing across the United States and across the world.
Good Lord. Well, I mean, is there a role for transplants other than living donors? But living donors.
Yeah.
But
living donors. I am not against transplant. I have friends who, they gave, the mother gave her kidney to her daughter, and this daughter's lived for more than 30 years and is doing well. I'm a big proponent of living donation. And this is something that, is an ethical, wonderful, altruistic thing people can do. A perfect stranger decided to donate her kidney and helped a nurse in my clinic. It's a pain clinic where I work. I mean, this is something we can all do to help one another, and it's very ethical, and it's something we should encourage. But the problem is all these unethical ways of taking organs from people need to be exposed. I think it's very unjust that the people being asked to give the organs are not told about these things. And I'm so encouraged, that HHS with RFK Jr. are actually looking into this process because of the egregious things that are going on. I don't know if you heard the case that started the HHS inquiry, the TJ Hoover case. He was supposedly brain dead, but on the way to organ procurement, he was thrashing and moving around, and he was crying. And the family said, well, what's this? And the organ procurement people said, oh, that's just reflexes. When two surgeons refused to remove Mr. Hoover's organs, reportedly from whistleblowers, the OPO team was told just to find another doctor, which thankfully they weren't able to. Mr. Hoover made a recovery and was able to get so much better that he was able to dance at a family wedding some years later. I mean, these things are absolutely needing to be stopped, and we need to be looking at doing things in an ethical way. I say to people, what if in 1968 we had decided heart disease or cancer was too difficult, and we just gave up on these patients? I mean, we've really shot ourselves in the foot for neurological care by saying that the most difficult people are just, they're too hard to treat, and we're going to make them into organ donors. We are 60 years behind where we should be in neurological care for people. We would have a lot more to offer people with all types of neurologic spectrum diseases if we hadn't been writing off the hard cases.
What can people do to protect themselves? I know you go to the DMV and you basically have to opt out of organ donation. Is that right? Can somebody, if you just get wheeled into the hospital and there's no family there and they look at your driver's license, is that all they need to go off of?
It's very tricky because most people do believe that we have an opt-in system, and they believe if they haven't opted into being an organ donor, they think they're safe, which is not at all the case. In 2006, the Uniform Anatomical Gift Act was revised to require a specific refusal to donate. Because if, in the case you mentioned, if I would come into a hospital and I'm incapacitated, I can't communicate, and if my family or healthcare surrogate can't be found in a timely fashion, the hospital administrator is empowered to donate my organs or body on my behalf.
Mm.
And there's actually a court case going on in New York State about this. An elderly grandma with a little dementia, her name was Miriam Hoyos de Baldrich, wandered away from home and unfortunately got hit by a subway train and was taken to a New York hospital. Now, her family says there was information in her pocket that would have led to her identification, and they had filed a missing vulnerable adult report. But at the hospital, they said they couldn't find any specific refusal for this woman about not wanting to be a donor. And she went ahead and actually was, in blunt terms, she was killed by the removal of her organs, and that's how she died. Her family is suing, and I hope it goes somewhere, but that is the letter of the law. So I tell people I don't recommend that anybody should be a registered organ donor, because that is legally binding. I mean, if you sign an organ donor registration, organ procurement organizations have successfully sued in court over families' objections and have taken organs from people where the family objected because that person had signed a donor card without any informed consent, not knowing what it meant and what it would do to their family. So I say I would not be a registered organ donor. On my website, there is a button. If you go to www.respectforhumanlife.com and scroll down the home page, there is a button talking about how you can get off the donor list and how to check the National Donor Registry if you think you might be on that list. There's also links to a life-affirming healthcare power of attorney document so that you have the instructions made for those who will be making decisions for you about your wishes in this regard. And there's also a link to a I refuse to donate wallet card that you can fold around your driver's license just to make everything clear.
Wow. And you also have a book. Tell us the name of your book.
Yeah, my book is called The Brain Death Fallacy. And if you're a doctor or a nurse, it's fully referenced. And again, I always like to offer, just sort of a word of encouragement to doctors and nurses. Like me, you were told that this is the thing, this was science. And as doctors and nurses, there's no way we can possibly personally research everything we are taught. We're forced to take so much on the basis of our authorities who learned it from their authorities. So in The Brain Death Fallacy, I've got all the references there that you can see where this information came from. So you can understand how on earth this all came to be. And then in addition to the website, then I also have my YouTube channel where I have, if you have family members that maybe are medically inclined, I've made some very short, easy to understand videos about brain death, controlled donation after circulatory death, NRP, what about donating your body to science, all kinds of interesting things. And again, nobody likes to think about death, but I do recommend, please look at these things when you're, clothed and in your right mind. I mean, don't wait until the worst day of your life happens and you haven't eaten, you haven't slept, you're looking at a loved one on a ventilator. It's going to be very difficult at that time to make a good decision. Look at these things now and decide what's right for you.
Yeah, excellent advice. Well, thank you so much, Heidi, for coming on. This was very interesting and a wealth of knowledge, and I really appreciate you coming on.
Thank you so much.